Thank you and welcome to another I3 webinar. Tonight we will focus on Africa. I'm joining with my co-host, Dr. Giles Palmer, as an embryologist and executive director for the International IVF Initiative, Professor Silke Dyer, who is an obstetrician and gynecologist and reproductive medicine subspecialist. She is the director of ANARA, the African Network and Registry for Assisted Reproductive Technologies, and the clinical data director of the International Committee for Monitoring Assisted Reproductive Techniques. She serves on the Science and Technology Advisory Group, Sexual and Reproductive Health and Research of the World Health Organization, and on the Educational Committee of the International Federation of Fertility Societies. And Dr. Adedamilola Atiba-Sogules, or you can say Dami, an accomplished senior clinical embryologist with over 13 years of experience, including a decade in Africa and currently practicing in Canada.
Thank you so much, Manar, for the introduction. Manar Hozyen is an ASHRAE certified senior clinical embryologist, American board certified as embryology laboratory scientist and medical technologist. And he's a board member of the Egyptian Society of Embryology and ART. She is currently working at Ghanin Fertility Center in Egypt with over 10 years of experience in the ART field. And she is well equipped with a knowledge of IVF lab, quality control, work ethics, technical work, and troubleshooting. Now, we're going to keep the bios short to get as much as possible out of this webinar, but you will find the full bios and all the I3 webinars on ivfmeeting.com. Remember, the certificates are posted in a few days and it's not immediate. Tonight, we ask that you place all your questions in the Q&A section and not on the chat so that we can keep up with it. And please, we ask that you take part in the discussion.
Hello, and a very warm welcome to you all, also from my side. Thank you so much for joining us. It is a great honor and a joy to be here with you and with our esteemed speakers to hear and talk about assisted reproductive technology in Africa. Africa is a beautiful continent. It is colorful, it is vibrant, it is diverse, and that also comprises the landscapes of ART in Africa. And today in the webinar, we will be hearing about activities that are impacting these landscapes that are rapidly expanding and evolving. And although the activities that we will hear about in the webinar are quite diverse, they have a common core. They recognize, we will hear about the importance of scientific data. Our continent, our region needs scientific data, real-world data, clinical, laboratory, genetic data. And the other commonality is collaboration, working together in the development of our region as we widen access to care and strengthen the quality of ART that we deliver. So I greatly look forward to the presentations and to the discussions afterwards.
Thank you, everybody, and what a fantastic introduction. So I think we will begin. Our first speaker, Paversan Archary, is a clinical assistant of the African Network and Registry for Art. Also, the regional contribution to the International Committee monitoring ART. He is in clinical academic practice at 2 military hospitals and Grote Schuur Hospital, the University of Cape Town. So it's a great pleasure to hear you speak, Pav. Over to you.
Thank you, and a warm good evening from Cape Town, South Africa. It's my pleasure to begin this evening's program with some facts and figures from the African Network and Registry for ART. I'm sure that everybody working in the field of ART is well aware of the global burden of infertility disease and its increasing recognition as a global public health concern. Indeed, it has a significant impact on the sexual and reproductive health and rights of women worldwide. And equitable access to infertility care is as effective as preventive strategies. Indeed, addressing infertility through equitable access to care is, of course, central to achieving the Sustainable Development Goals 3 and 5, which ensure healthy lives and well-being of all, and to achieve gender equality and empowerment of all women and girls. Earlier this year, new infertility prevalence estimates from the World Health Organization suggested that infertility is perhaps more prevalent than originally thought, affecting about 1 in 6 people in their lifetimes. And somewhat surprisingly to many, that infertility affects all countries indiscriminately, regardless of their socioeconomic status. We'd like to argue, however, that perhaps the individual burden of infertility placed on women in lower and middle income countries, and particularly those from Africa, may be significantly greater. In traditional African societies, the status of motherhood is revered and venerated above all else. And nowhere is this more beautifully illustrated in the traditional South African culture, where a woman's name and identity in the community quite literally changes and is uplifted from sister someone to mother of someone once she has a child. This indeed demonstrates how greatly a woman's status and position in her community is influenced by her ability to bear children. And of course begs the question, what becomes of the mothers of nobody who are often unable to achieve such a standing in their family or community, and are left with the physical and emotional suffering which ultimately affects their well-being? Now, we're aware that IVF is perhaps the most effective and efficient treatment for infertility, and it has been in practice in Africa ever since its inception into mainstream medicine, with pioneers from the African continent actively contributing to the clinical and laboratory practice we all know and accept as routine. Access to ART care, however, in Africa has remained fragmented and almost exclusively available in the private sector, often at unattainable cost and catastrophic cost to those that suffer the most. Furthermore, ART that is practiced has for a long time gone largely undocumented. And this has begged the question, what indeed is the availability, utilization, effectiveness, and safety of ART in Africa? And in the interest of improving access to care on the continent, it became abundantly clear that these questions first needed to be addressed systematically and reliably. Now, worldwide, national, regional, and global ART data registries document and monitor ART activity, creating visibility of numerous indicators by region and time. Africa has, of course, lagged far behind, and for many years, the landscape of ART has been characterized by sparse data, little collaboration, and scant government interest. And recognizing the need to bring Africa together to improve access to care, the African Network and Registry was established in 2015 as the regional registry unifying regional reproductive network for Africa. Our vision and mission are threefold. One, to generate real-world scientific data regarding the availability, utilization, effectiveness, and safety of ART in Africa. And two, to foster regional and international collaboration to uplift ART practice on the continent. And three, to develop skills and a deeper understanding of scientific data, its value, and to use the data to generate and direct action towards improved outcomes. Let's take a look at some of the data and explore how these are bringing visibility to ART practice in Africa. We are indeed the youngest registry in the world, and in 2019, first published data pertaining to ART cycles undertaken in 2013. In 2020, a 5-year trend report fast-tracked our reporting, bringing us in line with other world regions. And our third report, detailing ART procedures undertaken in 2018 and 2019, were published in January this year. We are currently working on our 2020 and 2021 data and look forward to sharing these with you in the coming months. For the purposes of this presentation, however, I'll be focusing mainly on our most recent 2018 and 2019 publication. Almost 44,000 cycles from 67 centers and 16 countries were reported in 2018, increasing to 45,000 cycles from 70 centers and 18 countries in 2019. Of course, as you can all imagine, delays caused by the global pandemic affected the timely reporting and analyses of these data. As an overview, autologous fresh IVF and ICSI remain the most predominant procedure, representing over 70% of all transfers, with autologous FET, fresh and frozen oocyte donation, frozen thawed oocyte transfers, and fertility preservation procedures making up the remainder. There's been an increase in autologous frozen embryo transfer cycles, evidenced by the proportion of autologous FETs over all autologous transfers, reaching about 30% in 2019. Effectiveness has remained relatively stable, with the clinical pregnancy rate per embryo transfer in autologous cycles remaining at around 39% and above since 2013. And effectiveness in frozen embryo transfer cycles has shown a steady increase, but not quite surpassed that of fresh cycles in the 2018-2019 dataset. We'll discuss these in a little bit more detail in slides to come. Our data are unfortunately not robust enough as yet to confidently report on delivery rates or cumulative live birth rates as markers of effectiveness, and much work is still going into improving reporting in this regard. Though there were a number of interesting findings throughout our paper, for the purposes of this evening's meeting, I'd like to focus on three key findings, namely that ART utilization is low, that women undergoing ART in Africa are young, and that the predominant practice results in a high multiple delivery rate and poor perinatal outcomes. Let us look at these in greater detail. Firstly, ART utilization, represented as the number of ART cycles undertaken in a region per million population, is perhaps the most useful, albeit surrogate marker of access to ART care. Now, ART care is underpinned by the domains of availability, accessibility, acceptability, and quality of care, all of which, once fulfilled, allows people the ability to realize access and then to utilize it. It therefore follows that the number of people utilizing ART is a useful reflection of how good access to care is within a region. And it is for this reason that ART utilization has been adopted as the global proxy indicator for access to care. Unsurprisingly, ART utilization, and by extension, access to care in Africa, remains low at less than 100 cycles per million population, falling far short of the 1,500 cycles that has been suggested as the requirement to meet the baseline need for ART. Of course, it bears mention that this is only the reported utilization calculated using only reported cycles, and though our experience leads us to believe that the unreported proportion would not be sufficient enough to make the difference. In short, access to ART care in Africa is low, and strategies to improve this are of vital importance. The second key finding is that in Africa, the majority of patients undergoing autologous ART are young. In the 2018-2019 cycle-based data, the mean age of women was 33.8 years of age, which many in this audience, I'm sure, would appreciate is a stark contrast to other world regions. This, of course, opens a number of interesting questions about the drivers of this, and will be interesting to monitor how this evolves over time to come. But regardless, it's important to accept that compared to other world regions, in Africa, we are dealing with a good prognosis population, and this should in turn inform clinical practice. Perhaps the most sobering finding is that at least 1 in 4 of our reported deliveries is a multiple delivery. The constant and high multiple delivery rates in all categories of ART procedures is not a surprising finding, and has already been highlighted in our 2 previous papers. The main driving force behind this being the practice of the transferring multiple embryos. Indeed, in 2018 and 2019, 85% of embryo transfers involve the transfer of 2 or more embryos, and a staggering 45% of transfers involve the transfer of 3 or more embryos. Now, understanding the factors underpinning this practice is key to overcoming it. The first is perhaps the belief that the transfer of multiple embryos is advantageous to achieving a pregnancy. Our data have clearly demonstrated that the elective transfer of a single good quality embryo is as effective and safer than the routine transfer of multiples. The second important factor is perhaps that in many instances, our patients have incurred such deep expenses to achieve ART that realistically and financially, they may have only one chance at an embryo transfer. The fresh transfer of multiple embryos is therefore prioritized in the hopes of maximizing the chances of a pregnancy. A third vitally important factor is that perhaps embryo cryopreservation may not be as yet well established in all areas. Therefore, a suitable avenue for the use of surplus embryos in some cases simply does not exist. In these instances, the transferring of surplus embryos becomes preferable to discarding them. The key consequence, of course, of multiple deliveries is illustrated in this slide, showing gestational age at delivery by order of gestation. 79% of singletons were born at term, compared to only 39% of twins and 6% of higher order multiples. Furthermore, 12% of twins and 38% of triplets were born extremely preterm at gestational ages less than 32 weeks gestation. Looking further into neonatal outcomes, the perinatal mortality rate calculated for neonates with reported birth outcomes was 28 per 1,000 for singletons, 69 per 1,000 for twins, and 194 per 1,000 for babies born as higher multiples. Although this documented perinatal mortality rate must be interpreted within the context of small numbers, a profound difference clearly exists between singletons and multiples. Multiple gestation is, of course, a leading risk factor for adverse outcomes of mothers and offsprings, a risk which is of particular concern in our region, which is well known to have one of the highest burdens of obstetric morbidity worldwide. Indeed, the benefits of ART should not compromise progress towards SDG 3.2, which is to end preventable deaths of newborns and to reduce neonatal and childhood mortality. As previously mentioned, strengthening of embryo cryopreservation capacity may be considered one of the more crucial steps towards improving ART safety. In this slide, the pooled data for all years shows autologous fresh and frozen embryo transfers as proportions of all autologous transfers by year, indicating once more that fresh transfer remains the mainstay of practice, despite a steady but slow increase in the proportion of frozen transfers. Indicated here in yellow, beginning at about 17% in 2013 when we first reported data, to about 36% in our forthcoming unpublished 2020 data. This slow increase in utilization has been accompanied by a concomitant increase in the effectiveness of FET cycles, where our data have shown a narrowing in the effectiveness gap between fresh and frozen cycles, with reference again to our forthcoming 2020 data, suggesting for the first time equivalent effectiveness in this data set. In most other world regions, this so-called effectiveness transition has already occurred some time ago. Indeed, with our own sister registry in Latin America, demonstrating this transition about 5 to 6 years ago, and who have shown quite beautifully in their own reports how this has resulted in a reduction in the mean number of embryos transferred and, of course, multiple deliveries. This would suggest that the effectiveness of FET cycles is somewhat reliant on experience and skills and expertise, as well as the infrastructure required for blastocyst culture and vitrification. And this becomes a cycle promoting each other as we go along. Within the context of these three important findings, three key actionable messages do stand out. The first is that ART utilization and by extension access to infertility care is low, and that strategies to improve availability, effectiveness, utilization, and safety are paramount to improving them. Two, that we are dealing with a good prognosis population in Africa and therefore need not primarily rely on multiple embryo transfers to achieve the best chances of a pregnancy. Our data have reassured us that the elective single embryo transfer strategy is a good compromise between safety and effectiveness, particularly in a good prognosis population. Thirdly, that investment in skills and expertise in embryo cryopreservation could be a useful mechanism to lower the rate of multiples without embryo wastage. We're now able to see from the information just presented the value of registry data in creating visibility of ART indicators over time. Now that these indicators pertaining to the availability, utilization, effectiveness, and safety of ART have been documented, we can begin exploring the factors driving this practice and engaging with them meaningfully at different levels. Through closure of the audit cycle and through feedback to ART providers, patients, policymakers, and funders, these data are able to inform ART practice, education, training, and policy, and hence improve access to care. We could conclude at this note by saying that ART data monitoring has been successfully established in Africa and is creating an evidence-based benchmark towards widening access to quality infertility care on the continent. But quality care requires quality data, and through the remaining components of our vision and mission, ANARA is attempting to improve data quality through collaboration. Firstly, through the development of collaborative networks, the registry is aiming to bring value to what lies upstream of data collection, which is the harmonization of people and data. ANARA is in local and regional collaboration with numerous fertility societies across the continent. And local collaborations do not merely involve partnerships to facilitate data collection, but also in assisting societies in their mandate to improve access to infertility care in their respective countries. One such example of this is in South Africa, where the South African Society for Reproductive Medicine has been successfully campaigning to medical funders for the subsidization of ART care. And registry data were instrumental in demonstrating the significant cost effectiveness of a singleton pregnancy resulting from a subsidized ART cycle compared to a patient-funded cycle with multiple embryo transfers and the additional costs of neonatal care. ANARA is, of course, also in South-South cooperation with the Latin American registry, Red Lara, with both registries benefiting from a shared and independently run software, and also from the collective expertise built up between the two organizations. We are also in triangular cooperation with ICMAR, the International Committee Monitoring ART, and through these partnerships, expanding the capabilities of each individual organization in turn. Of course, robust data requires a deep appreciation of the data being collected, and it is for this reason that ANARA has developed the Registry Data Online course, which is a 2-week online learning module aiming to grow participants' competence, confidence, and enjoyment in generating scientific data. And whilst this course is primarily aimed at users of the ANARA software, the learning material has been specifically designed to benefit anyone interested in the field of ART registry data. Participation is, of course, free, and further details are available via the ANARA website. And finally, quality data, strong collaborations, and robust skills come together to facilitate professional governance, capacity building, evidence-based practice, and a better representation of ART centers in order to overall improve ART access to care on our continent. And a final thank you to all of the participating centers who have kindly submitted data to us over the last few years.
Thank you so much, Dr. Paversan, for that wonderful presentation, showing the synopsis of ART practice in Africa, where we are and where we hope to be. Quickly, before we go to the next presentation, we're going to take a very short question. I do know that you mentioned in your presentation that we have the youngest registry in the world. So do you collaborate with any other registry outside of the continent, or are there plans to do that?
Yes, of course. Like I said, we are in South-South cooperation with the Latin American registry, Red Lara. We've benefited greatly from the interchange of ideas. Not only do we share our registry software, but also the expertise, and we've drawn on I think they've got more than 30 years of expertise in collecting data. So they've really guided us and continue to be an inspiration to us, and guiding us as we develop the registry moving forward.
Okay, thank you. I'm sure we'll have more questions for you after now. We'll move on to the next speaker. This talk is kindly sponsored by Cooper Surgical and will be given by Dr. David Moroll. Dr. Moroll has worked as a clinical embryologist since 1986, training in Manchester, UK, where he also completed his PhD studies. He has managed several laboratories in the UK and consulted laboratories internationally. Among other professional activities, he previously served as chair of the UK Association of Clinical Embryologists and UK Association of Biomedical Andrologists. He joined Origio, now Cooper Surgical, in November 2011. And in his current role as Director of Clinical Support, Dr. Moroll is part of the Professional Education and Clinical Support team. He provides technical and scientific support as well as education and training. Dr. Moroll, you have the floor.
Thank you for that introduction, Dami. It's a real pleasure to participate in this I3 webinar. I have a long-standing connection with IVF in Africa, which I'll come back to later. And it's an extra positive to me that I'm on the program with my friend, Dr. Ibrahim Wada, with whom I worked way back at the start of my career in IVF in Manchester, where we both worked with another significant African involved in IVF, Brian Lieberman, who set up the NHS IVF unit at St Mary's in Manchester, and sadly passed away in February earlier this year. What I'm aiming to do in this presentation is to look at the role of training in embryology and how we are currently supporting it. Dr. Archary has really covered some of the key challenges, but just to emphasize that again, let's look at some of the obvious challenges. And presenting a world map of gross national income per capita shows that Africa generally has the lowest incomes by country, as shown by the lighter blue colors in the graphic on this slide. And if we look at specific examples, we see figures of around $6,500 US gross national income per capita for South Africa, around 2,000 for Nigeria, and just $650 US for Sudan. And putting that into perspective, figures for Uruguay, Japan, and the USA are around $16,000, $42,000, and $71,000 respectively. And it's also worth stressing that it shows how variable the situation is across Africa, this huge and varied continent. Income's important because, again, as we've already heard, access to treatment is difficult. And a recent publication shown here from Njagi and colleagues reported that IVF typically costs twice the gross domestic product per capita as an average in Africa, essentially making it unaffordable for the majority. Interestingly, the paper also highlighted that the lower relative costs in other low-income regions are a product of government funding and ART regulations, and this is relevant as both are largely absent in many African countries. Now, in exploring for this presentation, I inevitably looked at some of the obvious remedies that we would be able to develop, and ones that have been developed to offer low-cost assisted reproduction procedures using modified stimulation regimens, simpler equipment, and simplified lab processes. And it's worth highlighting that in the March edition this year of ESHRE's Focus on Reproduction, they picked up on that and highlighted that these low-cost methods have not been widely adopted and had not contributed to reduced costs or improved affordability across the world, but specifically in Africa. And it also highlighted that the human resources, funding and supplies are consistently flagged up as the key issues to be addressed, alongside those government policies and governance in the field of ART. These factors are picked up as well in this paper, which details 19 steps. There aren't 19 on that list there, they're not all there, but 19 steps for establishing assisted reproductive technologies in low-income countries that were detailed here back in this 2008 paper by Professor Ian Cook, along with distinguished collaborators. Now, Professor Cook has long been involved in working towards providing better services in Africa. Again, these same factors are brought to the fore, that support to clinicians and embryologists, premises, staff training, and supplies and reliable deliveries of equipment and consumables. These factors are consistently coming up as important things that need to be addressed. And we'll look at these and see what we're managing to do now. So what can we do? What can we do to help? If we split this into the three sections, education and training, clinical support, and supply, we can look in a little bit more detail in what we're doing across Africa now. And in terms of the education and training, it's a case that we're unable to reach every individual. We can't realistically reach every professional working within the field of medically assisted reproduction, but we can aim to train the trainers so knowledge sharing is effectively managed and that knowledge is dispersed across the countries that we are dealing with. Of course, webinars like this, given and supported by I3, are a massive help. Now, it's also worth mentioning, as again has been already highlighted, is that things vary across the continent. I'm in the privileged position in the UK that we have very structured training programs. They weren't there when I first started, but they're in place now. We have a system of state registration and continuing professional development. And we're perhaps almost unique in that clinical embryology is a legally recognised profession in the UK. Now, that's very unusual, and few countries have such well-developed programs. But it's perhaps worth highlighting South Africa, which has a very long, successful history in the field of ART. I know there's been an IVF unit in Cape Town since, I believe, 1984. And it's not only supported education across Africa, but has also worked and developed a recognised system of training for embryologists. I'd like to thank Professor Manar Hozyen at the University of Pretoria for this information, which I hope I've correctly summarised. And in South Africa, they have systems for training of scientists, medical biological scientists, and medical scientists trained under the auspices of the Committee of Medical Science. And they also have the option of going into the field through the post of clinical technologist, using curricula developed by the South African University of Technology and operated under the auspices of the Health Professions Council of South Africa. That's just highlighting the fact that South Africa has a very well established way of training, which is missing not only in countries around Africa, but beyond that as well. Now, we can approach things slightly differently, and academic training is perhaps a good start. And I've taken this information as an example from the Oxford University website, which gives details of the access to their clinical embryology course. And it's interesting because what they highlight on their website is that they have graduates in their clinical embryology master's course from some 56 countries globally. And 7 of those countries are in Africa. So you'll see that there have been people graduate from the master's course from Egypt, Sudan, South Sudan, Uganda, Ghana, Nigeria, and South Africa. And we know that there are many other master's programs around the world. And from my time teaching on the Leeds master's program, I sense that this is probably typical. And the strength of this potentially is that it gives us the base of a core scientific talent pool from Africa that we can use to build our knowledge sharing. Now, we add to this by providing additional practical training as well as theoretical learning. And this is really the purposes of our centres of excellence. These are regional training labs that support hands-on training in these specific ART procedures. And if you take a glimpse at this particular slide, you've probably noticed that for now at least, we don't have one in Africa. But let's see what we're doing in the meantime. Now, using our programs as an example, this is accessing online training, so our virtual courses and so on. And what we see here is that around about 6 or 7%, this is data from 2022 and up to date so far this year, around 6 to 7% of participants in our online training are based in Africa. The vast majority, as shown in the blue, are from Europe, and the Middle East is the orange. That's perhaps not surprising because most of these events are run on Central European time, which is why we tend to see fewer participants from the Americas and from the Asia Pacific region. But actually most of Africa is on a similar time zone to Central Europe. So we would hope to get greater attendance from this region. So maybe in the discussion we can work out how to improve that access. When we look at the participants by subject and country, the numbers are small, but we see an obvious interest in the more advanced techniques such as embryo biopsy and ICSI, and ICSI is a recurring theme, we'll see that. But we also cover things like vitrification and laboratory design courses. And if we look by country, from Egypt, the interest has been vitrification and lab design. For Mali, it was embryo biopsy. Mauritius, also lab design. Nigeria, as where the largest number of attendees tends to come from. We've seen people attend for biopsy, ICSI, vitrification, and quality control courses. From South Africa, it's focused on embryo biopsy, and from Tunisia, biopsy and ICSI. So again, primarily on the micromanipulation. Now, if we extend this to online resources, generally we have a knowledge hub with a webinar library, white papers and various scientific literature. And what's interesting here is that of all the page views for our webinars in our webinar library, only 2.6% of the page views are from Africa. Now, what we're not quite sure is that I'm told that Africans are big users of VPNs, so we're almost certainly underestimating the true level of use. But what we want to do is promote use of those online resources to help drive knowledge sharing and improvement in practices. Again, you can see slightly more use for some of the other areas of the Knowledge Hub and scientific papers. And as I've already mentioned, it's noticeable that by far the most popular topic that we see being used in online resources is targeted towards ICSI. Now, when it comes to the hands-on training at our Centre for Excellence, it's inevitably much lower. And although 2023 shows a higher figure due to specific groups attending, otherwise the access is actually quite limited, and more familiarly, it would be around the 1 to 2% of participants coming from Africa. And we know why that is. Largely, it's down to cost. And it's down to visas, and it's where the hands-on attendance has been possible. Again, it's those micromanipulation procedures, primarily embryo biopsy and ICSI. And visas are a problem. It's a significant hurdle for visitors from Africa to get to our centres of training primarily based in Belgium, and visas to the Schengen area are particularly difficult. It's difficult for people from other areas as well, but it seems to be a particular hurdle for our African colleagues. I did check whether any African embryologists make their way over to our training lab in Mumbai. Nobody has done that so far, and I'm not sure whether that's any easier. So given those difficulties, we have a commitment to providing local training as well, which is hugely important, and there we're as active as we can be. Just show you this infographic, which shows the workshops that we've done over the last couple of years. And you'll see that they're dispersed around Africa, covering things like general IVF workshops, vitrification, and more advanced techniques like embryo biopsy, the most recent being in Nigeria. And that particular biopsy training event in Abuja back in May, I've got these lovely photos. These were quite interesting. They were hugely popular. We were turning people away, and it's very obvious that if we can get on site and provide local training, the enthusiasm for that is really serious, and we could hold many more if we had capacity. So just for example, we would usually give a biopsy hands-on course with 2 trainers and maybe 6 to 8 participants. Over the 2 days of workshops I gave in Abuja, we had 28 participants, myself as the trainer, thankfully helped by the local embryology team, lots of questions and a bucket load of enthusiasm. It was a really exciting event. Now, we also deal with other advanced topics like sperm selection we've run in South Africa, and this one on ovarian tissue cryopreservation. So very advanced techniques, in this case, both supported by our local partner, Harry Labs, with the ovarian tissue cryopreservation being in partnership with Planer. Now, we also get involved as well as training. We have the professional education and clinical support team that I'm a member of. We are a small band of very experienced embryologists that provide advice and support to labs. having problems, troubleshooting, wanted to review procedures and so on. And this small group of embryologists in our PECS team, I've calculated, has well over 200 years combined experience in the field. So we can provide quite considerable support. And one area that I have a particular interest in is laboratory design, and I help run the virtual courses, and I also help with my colleagues to provide support to individual labs that are looking at refurbishing or even building new laboratories. So that's also available from us. Finally, I mentioned supplies as a key factor that comes up in the literature. And here, the key message is that the role of local partners is paramount, providing a more reliable supply chain, acting as the conduit to the clinical support functions within the wider organisation. And they are also generally the people that request and support local training activities. And above all, they're closer to the action and more attuned to local needs. Engage with your local guys, and they will hopefully help drive training activities more locally. And again, taking Cooper Surgical as my example, and I'm sure other organisations will mirror this. This map simply shows all those countries across Africa where we are covered by local partners for products and services, which I think illustrates that we have pretty good coverage. And as I say, because they are the conduit to training and education from our global organisation, that's an important factor to bear in mind. So just quickly to summarise, low-cost IVF may be available, but seems to have done relatively little to improve affordability, unfortunately. Training, support and supplies are where we can really help and are clearly important factors. Supporting education and training of embryologists is critical, and whilst hands-on training is popular, the centralised training facilities we know can be difficult to access, so we need to find ways to manage that. Those local training activities can be difficult to organise, but it's really rewarding. So we will do our best to do more. And local partners channeling supplies and supporting training are an essential part of the overall system. Now, I mentioned at the beginning that IVF in Africa had a personal element to me. And I just wanted to show you this. This is, I blocked out some faces because I don't, that they were patients. But in the mid-1990s, I was lucky to undertake trips to Zimbabwe to help Tony Robertson here, a gynecologist, and his wife Fiona, who was, I believe, a plant geneticist by training, but a fabulous embryologist. And we helped to provide IVF in batches for the patients of the Zimbabwe IVF program. And this fairly recently, I believe, relaunched as IVF Zimbabwe. And working there in the 1990s was a huge eye-opener, a fantastic learning experience. And along with Dr. Karen Turner here, we had some success, including what we believe was the first ICSI baby conceived in the lab in Zimbabwe. And we did that using a micromanipulator system borrowed from the local Tobacco Research Institute. So we had some work to do with there. And that's just highlighting the fact it was a wonderful experience. I had very many treasured memories, as well as this commemorative tankard. So I'll end by just showing my bibliography, and then finally thanking my colleagues at Cooper Surgical, not least members of the team that cover Africa, my PECS colleagues and marketing for their help with this presentation. And once again, thanks to Professor Karin Heuser for her help and guidance on some of the information there. And of course, thank you for listening to me.
Thank you, Dr. David, for this amazing presentation. Actually, I have one question about supplies and media. What about the challenges that you face regarding the media that should be kept in low temperature in the warmer countries?
Yeah, this isn't unique to Africa. We get this across the globe where environmental conditions are particularly hot. That's a specific problem. Can also be a problem where it's very cold. What I can say is that the systems that we use have to be validated. So they are validated to maintain temperature within a specified range for a certain duration of time. So it should be possible for us to get supplies almost anywhere in validated storage conditions so that they arrive in good condition. And of course, what we always say is if that's not happening, get in touch and we'll try and work out what's going on and solve the problems for you.
Okay, thank you. Now with our next speaker, Dr. Ibrahim Wada. Dr. Ibrahim has an experience and perspective on PGT and sickle cell disease, which is very worthwhile contribution to our webinar. Dr. Wada is gynecologist, reproductive medicine specialist, and director of the NISA Medical Group. He is past president of Nigerian Fertility Society, special advisor of ECMART, a strong supporter of ANARA, and reader in obstetrics and gynecology of one of the public universities in Nigeria, which is developing research collaboration with NISA Medical Group. You can see his full bio on I3 website. Now with his talk, is pre-implantation genetic testing for prevention of sickle cell anemia sustainable in Nigeria? Welcome, Dr. Ibrahim.
Thank you very much. It's my pleasure to be on this program tonight. Thank you, Giles. Thank you, everyone who organized this. Thank you also, Dave Moroll, who's been my colleague for many years, and may the soul of Brian Lieberman rest in perfect peace. I have a very important question this evening for Nigeria and also for Africa. The question is, can we sustain pre-implantation genetic testing as a means of preventing sickle cell anemia in our population in a sustainable manner? And we all know that the gene frequency of sickle cell is very high in Nigeria. 25% of the population, they are carriers, and this is a huge disease burden. All options must be on the table to prevent and to make the life easier for the population. So I want to share with you this evening my experiences, my team's experiences and perspectives of doing PGT in Nigeria, directed essentially at the disease of sickle cell. This work that I'm talking about today is not supported by any grants, and as such, I don't have any type of conflict of interest at all. And I want to describe the experiences in setting up and using the PGT lab, the kind of results we got and the breakthrough, other perspectives, and what is my view of the future of applying the technology to sickle cell anemia in our region. The option became available with progress in what we know as single cell genetics. It means you can take one cell and analyze the whole genome sequencing of the chromosome in that single cell, and you will be able to make disease diagnosis, particularly where you are talking of single gene defects. We recall the breakthrough by Handyside, Alan Handyside and group in the early 90s in sickle cell anemia, cystic fibrosis, combining in vitro fertilization with pre-implantation genetic diagnosis. PGT-M here is PGT for testing monogenetic diseases. Now, in the low and middle income countries in this world, not much is known about applying this technology for sickle cell anemia or even related diseases because of clear reasons why high level of technology is difficult to sustain. And so what is sickle cell anemia? It is a gene defect where this red blood cells become sickle, I don't know if you've seen like a boomerang before. And these sickle cells, they're destroyed very easily, and they cause chronic anemia and many problems. We call them crises. So these people are in pain most of their life, and there are all sorts of complications and pain. And I've said before that 1 out of 4 in the African population, especially the Nigerian population, is a carrier state. Even though there's a lot being done to prevent marriage between carriers, that's not enough. All options must be on the table because prevention is always better than cure. I've illustrated here that the defect is in the beta globin chain and is born on chromosome 11, the HBB gene. This defect allows production of abnormal globin that alters the shape of the red cells, and the homozygous sickle cell SS or SC is anemic and in trouble. So the purpose of this work is to, against all local odds, establish a advanced PGT technology for monogenic diseases services in Nigeria and make it available as an option to prevent children being born with sickle cell anemia. But the bigger question is, okay, can this be sustained based on all factors in the economy, in the social, in the religious where people, they don't want you to interfere with creation in any way. How does this technology sit in Africa, especially in Nigeria? The first was, there was no lab before. We have to try and set up a pre-implantation genetic lab in Abuja, Nigeria. It is no mean feat. You can see the picture of the lab, part of the lab in the background. It's no mean feat to get your people trained, to seek collaborations where the technology is well rooted already. And here, I want to appreciate the work of Degan, who was in repro genetics in London, in Oxford, sorry, and the willingness to admit people from Africa to train and eventually getting the machinery which has the capability of doing both PGT and nucleoid screening as well as screening for sickle cell anemia, and indeed a lab that could also do many more genetic testings. And what is critical here is when we started to set up in 2014, by 2018, when we were ready to start, the technology we had put on ground was already obsolete. New technology for genetic testing had been developed. So we had to start all over again. And it's an experience to share because that's not easy where we are talking of low GDP, like my friend David Moroll has said when he was making his presentation. So nevertheless, we got on and we were able to bring up a even more advanced lab than we set up. The original one was just CGH array, but this one now is based on next generation sequencing. So how is PGT done for those who are not familiar with the lab? The biopsy is the Moroll has talked about embryo biopsy training. We have to do that to get someone capable of harmlessly biopsying an embryo so that the embryo can continue to live after the intrusion or invasion. And I'm very happy that there's more discussion on non-invasive PGT these days. And the Illumina, the DNA extraction, and all the other testing that is done before the genetic analysis to determine whether the embryo is HBAA normal, AS carrier, or affected, HBSS or SC, as the case may be. So this is the lab in pictures, a single cell. You do the DNA extraction and the analytic stage. And I don't know how clear the results page is, but the bars show SS on the left, AA normal on the right, and in between is HBAA. The idea is if you can find an embryo that is AA, all well and good. The couple who have a risk of having children with HBSS, they've already known they're not going to have HBSS. which is a very, very complicated life for both parents and the affected children, and even into their adult life, like I've described at the very beginning. So we will put in AA or AS and leave behind the sickle cell anemia affected embryos, which is an addition to the technology available to us to look after the disease condition in Nigeria. So here is it in pictures. And by 2018, we were lucky. This is a report of a breakthrough published in 2020, but the child was born late 2018. And we had shown for the very first time that pre-implantation genetic testing for sickle cell anemia could deliberately lead to the birth of a normal child for couples at risk. Now, this is not the first time this is done in the world. We're talking of 1990s. But thank God, at least with some hard work and investments, this technology could then, in that point, be said, it's on ground. And the couple are extremely happy that there was no risk that they could be carrying an affected child. The child was born at 38 weeks gestation, everything normal. Hemoglobin genotype testing at birth, HbAA, 9 months into life of the child, we were able to confirm the finding that, yes, we put HbAA embryo into the uterus of the mother after IVF and PGT, and truly the technology was able to prevent. But having said that, one breakthrough is not enough. If you are going to talk of sustainability, access, reproducibility, or ability to really influence the population, you need more data. So by 2022, 40 couples on our PGT-M arm, not PGT-A, with 210 embryos had gone through the PGT screening. Some of it had been done in Oxford at the very beginning of the work, but most of the embryos were analyzed locally in Nigeria. And I've described the possible results you will get. It's either abnormal, carrier, or affected. And here we are with more data, the age of the women. This time, the average age, 31 years, from 23 to 41. We said 201 embryos, that's about 5 embryos per patient. 27 women have had embryo transfers using normal or carrier embryos, and another 4 are waiting to have frozen embryo transfer. We were able to achieve 13 pregnancies. This is 48%. And at the time of analysis, of writing this analysis, there were 8 live births. I bet there are more now, but I've not gone to look at all that for this presentation. What are we beginning to see? At least in the embryos that survived the analysis, 62 of these ones, that's 38%, were affected. So this could have been potentially born to these couples as affected children, but technology has been able to weed them out. And so we have 56, 45 that were free embryos for transfer, either carriers or normal embryos. But this cannot answer the question that where you have embryos in your laboratory for carrier couples, what is the pattern of their genotype? The reason for that is there are embryos that we could not amplify, and this is pretty high, 19% almost, and 1% with contamination that messed up the work we were doing. Now, these are early days of this technology in our hands, and over time, we expect better training, more perfection. But there is no doubt that the point is being made, the technology is really available and able to prevent sickle cell anemia affected children. You will ask me, so in a country with the kind of challenges I described at the very beginning, from social, religious, and technical, and all those economic things, how could you get this far? And we thought, you will see that in the setup of the laboratory, there were issues concerning power. Power is not regular in this part of our world, and it's an important thing to produce different levels of power to sustain the energy supply to your machinery. Maintenance too, we have had to fly people from different parts of the world, including Silke, South Africa, Ivory Coast, and other parts of Africa to come in to do maintenance of either regular maintenance or when there's a downtime, and getting the logistics for getting the supplies. And I can remember importation issues. They are not used to this kind of materials. And so we had to go and defend almost every time there was an importation, and the cost of importation dancing with the unstable foreign currency that we are using. I've mentioned amplification failure, contamination, ADO. These are technical problems. They occur anywhere in the world. They occur also in Abuja. The ethical and societal considerations is to say that because there's only one center doing this, and that's in Abuja at the moment, it's not like the huge national debate that's going on. But what we saw in IVF is when it's one center or two, no big problem. But once more and more centers start coming, problems come, the legislators want to regulate. At the moment, we are not under any kind of major controls, but we are practicing based on ethics of care that we have learned during our work and training abroad. So be rest assured that we are not doing this willy-nilly. The indication must be very clear. Like has been said, a lot of advanced technology in medicine in Africa, people pay out of pocket, and many times what their GDP is per capita. And so this is a proof of concept more than anything else, hoping that eventually to be incorporated into insurance systems and research support that should be able to make this help mothers, especially those who already have one sickle cell affected child alive with them. It's very difficult to say, go ahead and try again. They will want to be more sure. The other ethical consideration is a big group of our people are not in support of prenatal diagnosis, where if there's an affected pregnancy, that pregnancy ought to be terminated. So it's so important that this technology is at least available as an option, and the support needed to make it more freely available will be really helpful. So how do I see sustainability? The uptake, 40 patients in our center, taking up this in more than 4 years, just over 4 years, that's not plenty, considering that millions of people are in a position to need the technology. It means access is low. Unless supported by the PGTA, the nucleoid screening, sex determination, or whatever it is that is justifiable and ethical, PGT for monogenic diseases alone will not stand, except there is a massive partnership across the country for monogenic diseases by IVF clinics. We have like 25 clinics partnering with us now, but there are more than 100 clinics in Nigeria alone. That expansion may sustain it. We need support for training more personnel as it expands, and better still, if we can put in other scopes of training of services like breast cancer screening and other disease screening and karyotyping, even the non-invasive perinatal testing genetics. So I want to conclude by saying clearly, pre-implantation genetic diagnosis for sickle cell anemia is on ground in Nigeria with difficulty, and I've shared my experiences with you. Not correct. Our is a whole team, as you will see at the end of this presentation, our experiences. But if we are to make it more readily available and accessible to the population that needs this in our part of the world, we must expand access. We must also expand the scope of genetic testing so that costs can come down as overheads are now shared by many other services, genetic services. I want to appreciate members of the genetics team in Abuja. The man on the right, lower right, Mohammed, is now abroad working, but he was really pivotal in the success of the team. And I appreciate all other members that you are seeing. And thank you very much for the time.
Thank you so much, Dr. Ibrahim, for a beautiful, scientific, and visionary presentation. You have shown us that it can be done. And I know there are a number of other projects that you are leading to show Africa that it can be done.
Thank you very much.
There are many questions here in the chat box, and I think we will come to the question and answer session later. But just one question that I want to ask, and I'm sharing it with Dr. Julian Mamiso, who is listening in Nigeria, but working in the UK. And the question is, surely this should be cost effective if we can reduce the burden of disease and use the resources on the care of those who have sickle cell anemia and move it into prevention. And I think it is so often the story of Africa, is it not, that we lose our resources in managing the burden of disease and we do not have the resources to effective prevention. You mentioned it, we need to reach government and the funders. What more can we do to fast track that?
I thank you very much, Professor Silke. So nice to share this platform with you. I think that we've done a proof of concept. It's not just one breakthrough. We have enough going with confidence now to be able to educate the public more about the availability of this option, the relevance. It's cheaper, no matter how expensive, than treating one child with sickle cell anemia in the lifetime, in the painful short lifetime. So advocacy time has come, and I'm so glad with this opportunity to tell the world Nigeria is the headquarters of sickle cell anemia. Some Nigerians, unsupported so far, have made this breakthrough and demonstrated sustainability. Will the world take note and support for humanity's sake? Thank you.
So well and truly spoken. Thank you so much. We will come back in the question and answer session. So now, before we get to question and answers, and again, there are many, many here in the chat box, we will have a video presentation bringing in other voices, colleagues working on ART in Africa.
Hello everyone, I am Dr. Zogman Abdali. I'm embryologist in Algeria. I work in private center since 2002. 20 years experience in our lab. The second IVF center in Algeria, and you do between 500 cycle years IVF.
Hello, I am Manar Hozyen. I am senior clinical embryologist at Ghanaian Fertility Center in Egypt. This is a big center here. We are performing about 1,800 to 2,000 cases per year.
Well, hello. I'm Professor Omar Sifriwi from Casablanca, Morocco. And I'm a gynecologist, IVF and reproductive surgeon specialist. I'm the general manager of the African Fertility Clinic in Casablanca, Morocco, which is the biggest IVF clinic in Morocco. We're doing more than 1,000 fresh cycles and around 1,500 cycles a year.
Hello, everyone. My name is Roslyn Obasa. I'm the laboratory manager at Nordic Fertility Center, located in Nigeria, one of the leading fertility centers in Nigeria. At Nordic Fertility Center, we've been helping or assisting couples to achieve their dreams of conceiving. And we've been doing this for 20 years and counting.
Hi, I'm Zuleika Williams. I work for Cape Fertility in Cape Town, South Africa. We are a large unit. We do about 1,500 cycles a year. Teresa?
Hi, I'm Teresa Ernest. I'm an embryologist at Cape Fertility in Cape Town, South Africa. We are a private clinic in Cape Town.
Hello, I am Salima Daoud from Tunisia. I am Associate Professor in Histology, Embryology, and Reproductive Biology in Hadi Shakr University Hospital in the city of Sfax in Tunisia. We are actually working on a project also to start an IVF center in my city in Sfax soon.
Hello, everyone. My name is Moses Tiri. I am a clinical embryologist in Kampala, Uganda. I work at Neogenesis Fertility Center. It is a fertility center that started in 2016 and has been operating since then. We do about 450 cycles every year.
IVF in Nigeria is the last country in North Africa, because the first opening IVF center is in 2000. Now we are actually 92 or 93 IVF private center in Nigeria. They grow up every year.
There are many IVF clinics in Egypt, either private or public. In general, it is cost about $500 per cycle without medication. So it is very cheap, but it is more affordable than the other countries.
And in Morocco, we have very clear data, and we have 12% of couples in Morocco who are of infertility issue, which is around 1 million couples. That means it's a real and huge problem. In Morocco, we have around 18 IVF clinics, which is probably low, and most of them are in the arches of Casablanca and Rabat, which are the biggest cities in Morocco.
In Nigeria, the embryology society that we have is the CEAN, CEAN, where embryologists actually come together like a group in Nigeria, and then we can share knowledge and communicate with each other. Actually, from an association of fertility and reproductive health, that's the AFRH. It's a fertility an association of IVF clinics in Nigeria. So embryologists also have the opportunity to interact in that group. The AFRH is actually the body governing all clinics in Nigeria in terms of set rules and everything about the IVF processes.
There are about 30 clinics in South Africa that provide some form of IVF. We have 3 government-funded clinics, and about 70% of the population is reliant on public health services.
There isn't an embryology committee as such. There is a group, a special interest group for embryologists that we are a part of, the Southern African Society of Reproductive Medicine and Gynecological Endoscopy. It is a voluntary group, and you do pay an annual fee to be involved, and they are responsible for running workshops, advertising jobs, academic programs, and other workshops.
A population of 11 million people, not too much. So we have in total 10 centers of IVF, 2 in the public sector and 8 in private sector.
IVF in Uganda has been around since 2014, and that has grown over time to about 8 clinics currently actively operating within Kampala. Unfortunately, all these clinics are located in the main city of Kampala, with none outside. People do travel in from other countries, the neighboring countries, from the DR Congo. We have people from Southern Sudan, and with the war in Northern Sudan right now, we do have people coming in to seek IVF. But by and large, majority of our clients are actually city-based. They're based within Kampala.
About the challenges, actually we faced many challenges here.
The challenge in Algeria, I know exactly what. It's genetic testing, because all IVF private don't do IVF PGTA or PGTD.
Number one, the lack of awareness about IVF technology. So leading some couples or delays to take the decision of IVF or ICSI, which means old age female with low reproductive outcome. Number two, the cost. We have high cost here compared to the low income. Number three, lot variations in medication, supplies, and media. Also, the most important issue is the research. Research here in low to middle income countries has the vocal opponent. So this leads to some dedicated researchers and embryologists to avoid conducting researches.
Top on the list is cost of IVF that's not affordable to majority of the people who need it within the country.
The main issue is probably the coverage, the insurance, and the government is doing a lot of effort actually, because since 2 years the government and the health maintenance organization covers the drugs, most of the drugs for IVF, so which is a real effort and a very positive step, but we're still waiting for the coverage of the whole attempt of IVF.
Tunisian health insurance system doesn't cover 100% the cost of IVF, so it's a partial coverage and is for up to 3 cycles. I hope that in the future we are working on to promote the coverage of the cost of IVF for low-income couples. And there are other challenges, new technologies, regulations. There is a project actually to revise the Tunisian law of reproductive medicine, and many aspects will be introduced. PGT, social freezing, social egg freezing, research on embryos, and many other aspects which are under revision.
IVF really it's not 100% accepted. We are still trying to make people understand, because there's some part of the countries who believe that you know, fertility would come, you know, they will get pregnant and continue trying until then. But the challenges that we have would be that in terms of training, I think it's mostly come from the private sector, where the managing directors are able to actually train. So clinics take it upon themselves to train the embryologists and then send us to congresses where we get to hone our skills and become better.
We don't have any training centers within the country. So everyone trained as an embryologist or an REI guy is trained outside the country. We usually travel to India, Australia. We have a couple of embryologists trained from Leeds University, a couple trained from Spain, and personally I'm trained from Monash University in Australia. We also do have challenges with the acquisition of plasticware and media. Currently, we get all our media from out, it's imported, and therefore, and there are no subsidies from the government. So taxes are pretty high on these plasticware and media.
The challenges that embryologists face is that there are few training spots available and few workspaces available. So it can take a long time before work becomes available, even though you have finished your training. And so for that reason, we find that embryologists are moving overseas, but also the more pay is also attractive for when they do move overseas.
Okay, thank you, everybody. Now it's time for the Q&A. If I could ask all the moderators and all the presenters to put on the cameras. We've got a lot of questions here. It's been a long time since we've seen so many questions of this caliber. I'll just start off, and then I'll seep into the background and let you do the talking. But I think I'll ask Pav, if I may, who started off with your talk in the session. How easy is it for the data collection, and how effective have some of your policies or some of your initiatives been, such as, you know, to reduce multiple pregnancies? Because it's a vast area, and of course it's a diverse area, and you know, and how do you manage that?
Thanks, Giles. I mean, it really isn't an easy job. Data collection in general hasn't really been part of the culture of ART practice for a number of years in Africa. So, I mean, it started with Silke campaigning tirelessly for years and years to bring in this process of the fact that we need data collection. And slowly, with centers actually seeing the value of data, beginning to start to show interest in collecting the data. I mean, I just want to share one story from my travels to Ghana, where I presented Ghanaian data. And one of the little centers jumped up and said they want to participate. And the center director ran to his car and brought out a little black notebook with handwritten cycles of all of the patients that he had been seeing. So, I mean, moving from that to the concept of actual data collection and using that to generate KRIs is a big step that we're asking of centers. So it really isn't that easy. On the other hand, the policies and initiatives that we have in place need to be supported by bigger initiatives like you know, policies from funders and governments and things like that, in order for them to make you know, greater impact. So it is a work in progress, and it's a work that's extremely rewarding. And like Silke said a little bit earlier, it's through collaboration that we're able to put this work together and move the continent forward.
Fantastic, thank you.
I have a question for Dr. Ibrahim, and it is from Bronte Stone. I don't quite know where Bronte Stone is at the moment, but she's asking a question about epidemiology. What is happening with sickle cell anemia in Nigeria? Is it increasing? Is it decreasing? Or is it staying the same?
Thank you very much, the person asking the question. The absolute statistics are very difficult to keep in our part of the world. The estimate is that 1% to 2% of our population have the disease state. This is hemoglobin SS or SC, or very few S-beta thalassemia. Then 25% are carriers of the gene, but they don't express any disease conditions. I don't suspect that there's an increase. Why? Because there's an increased awareness of screening the adults who want to get married. And so many people in true love are denied to marry because they are both AS and AS. Until and unless you go through that, you won't know how painful it is. So I think that's scratching on the disease burden, no doubt, but not significantly. The option of making a diagnosis of a fetus in the mother's womb, and you detect that the fetus is affected and you're going to terminate, for example, that again has all the problems with it. Are you anti-abortion? Is it normal to do this? But even if there's anything, it's hanging in there somewhere. So I think we can't say it's increasing, but at the same time, we have to appreciate that the burden is so strong that everything we can, every technology we have, which is ethical and social and economic, should be thrown at this problem. Thank you.
Thank you.
Thank you, Dr. Wada. My question is to Dr. Moroll. In your presentation, you mentioned knowledge sharing, which I quite agree with you. It's the basic foundation of ART laboratories all over the world and also in Africa. And looking through the comments, you would see that a lot of people, embryologists in Africa, are quite hungry for where to have that training. How do I get this training? And this is more or less like a call out to ART companies such as Cooper Surgical to see how we can bridge that knowledge gap, especially in Africa. So is there anything that Cooper Surgical has that is it in the works or currently accessible to upcoming embryologists in Africa? It's a good time for us to see what we have out there.
Yeah, thanks, Dami. I think this is a recurring question. Really, is how much support we can make available, and I think what we try to do. I think maybe the perception is that we have lots of people providing education and training. The professional education and clinical support team that I'm part of is, I think, 7 people working globally. We have additional resources available. So what we try to do is provide as much material as we can via online resources, via our knowledge hub on the website, and then through webinars. And I know that we've tended to focus on the Europe, Middle East and Africa region, so they've tended to be convenient for European time. What we're looking to do is create more live webinars and live activities for the Americas and Asia Pacific. But specifically for Africa, then most of our live webinars and the likes are easily accessible to African colleagues. The hands-on training is the difficult bit, and that's where our links with local partners is really helpful. So I mentioned activities that we've done in South Africa with our local partner Harry Labs there. We've done similar with the guys in Nigeria with the embryo biopsy training. And it is really a case of trying to encourage whoever your local contact is to pester us to get some local hands-on training for you. So the virtual stuff, it should be accessible to everyone. The hands-on, I know, is more difficult and we have limited capacity. We never meet demand that we get from not only Africa, but all the other regions. All I can suggest is keep asking, and the more you ask, the more likely somebody is to listen and we can help. It certainly isn't a lack of will. It's often a lack of time and resources, but we will help whenever we can.
Thank you. Do you think, this is just might be a little bit highfalutin, but do you think that the technology of virtual reality would be able to bridge that gap of hands-on training?
Yeah, you're probably asking the least technical savvy person on the call. But yeah, of course, we would love to be able to build platforms, whether they are VR or some sort of latest technology to support training. Again, we are taking our first baby steps in that sort of thing. We have a virtual lab that we show online, it's the first foray into something that could be more useful. I think Giles is much more adept at this sort of thing than me, but absolutely we would love to embrace that.
Yeah, thank you.
I have one question for our first speaker, Dr. Paversan. We have a lot of questions actually, but I will take one from Jurium Korendi. He asked about that many African countries. I'm sorry. Yes, this one. Talking about the understanding of the operation without clear or the procedures that doing without clear legal guidelines. How does the ANARA organization and the other collaboration pursue or encourage local legal guidelines for assisted reproductive technologies?
Thanks, Dr. Korendi, for that question. It again really is a difficult one to answer. There's varying levels of legal involvement and government involvement in ART across the continent, varying from absolutely no input from the government to strict restrictions on certain ART procedures in some countries, particularly regarding egg donation and things like that. So I think at the moment, our main focus is on bringing visibility to ART practice in the country, in the continent for that matter, and hopefully with bringing visibility to it, to start people having these conversations in terms of what needs to be regulated, what needs a little bit of less regulations, and what actually needs to be done to improve access to care and move that forward in countries. So at the moment, we're again still in very much baby steps in this regard. Thanks.
Thank you.
Yeah. Thank you.
Sorry. Is there a question, Silke? Sorry, I was just going to ask Dr. Wada about lab design. How difficult would it be, or was it, to design your lab for PGT? About finding local resources, lab materials, air quality. Was that an issue for you?
Thank you very much, Giles, for this question. Yes, but we were lucky that we have run IVF labs that have air quality control component. So that helped us in being aware. I think the greatest one about importing, getting the materials, equipment, and so on, our hands were held by our collaborating group in Oxford, like I said, and we took our way through customs, meaning they were not aware what this stuff were. And that was, but we overcame all that as well. So I think power that must never fail was, again, another consideration for our lab, but we got it in. We got it in. I think we were really motivated to achieve the goal. And so we overcame every obstacle that came. And we had partners. Like I said, I showed the man who came in from Illumina. He was in Tunisia at that time. We persuaded him to join us. And we had help from Oxford as well. So I think that answers the question, really. Difficult, but we did it.
Thank you.
Thank you, Giles.
Yeah, collaboration.
Yes.
Collaboration and partnerships. I think that is so often the answer. We've got a question here from Nigeria. So I'm going to, it is directed to Dr. Paz, but I'll send it to both your peer speakers. High percentage of triplets, wow. And we know that is due to the transfer of multiples. And so the question is, and I think it's a beautiful question, are we ready as Africans for SET? How can we move to SET? What must Africa do to achieve it? Is it technology? Is it AI? What is the answer? Let's hear from the registry first, and then maybe also from Dr. Ibrahim.
Thanks, and thanks to Joseph for bringing up that beautiful question. Yeah, I think the answer to that is that whether we are ready for it or not, we need to be. And by addressing this problem of high multiples head on and realizing it for the problem that it is actually the first step in addressing this. So I mean, moving on to SET and how to move that forward, it definitely does depend on building that infrastructure and capacity for channeling our surplus embryos into cryopreservation, and that's the only way that we're actually going to tackle that. Yeah, Dr. Wada, do you maybe some comments from your side?
Yes, please, Bev. My understanding of the question is it avoidance of multiple births? Silke, if you can please clarify the question a little bit for me, please.
Well, on the one hand, the concern is, wow, the high percentage of triplets. So I think on the one hand, and we probably all agree that our focus is initially to reduce the rate of triplets before we focus on the twins. But at the same time, our listener is asking, is Africa ready for single embryo transfer, elective single embryo transfer? So
Thank you very much, Prof. Thank you. My position is all the data in the world supports single embryo transfer. Even nature supports single embryo transfer. So there's no question. However, we've had the challenge in Africa of people who must pay out of pocket and have only one chance, and no support from any insurance, no support from any government. Every relative has chipped in one thing or the other to make you have an IVF, and you get that one chance. And of course, triplet pregnancy is not possible by it is a iatrogenic triplet pregnancy. I think is a medical malpractice, knowing what we know now. But we in Nigeria, in particular, the AFRH, settled on double embryo transfer 2, and exceptionally 3, maybe above the age of 40, something like that. And I think we're going to be in that wavelength for a while before, and what is the before? Some kind of financial support, some kind of reduced cost burden on individuals must come in to give them that option of, oh, you don't have to do it all at once. You can do it and come back for your frozen embryos. Your world doesn't close on one embryo transfer. And I think we must address that in the prescription. So our position in the AFRH Nigeria at the moment is to say, we will not support 3 embryos in anyone who is less than the age of 35. But particularly from the age of 40, we can still say that based on it's their eggs and their chances are a bit on the low side. But the ideal thing for any practitioner, without doubt, is to pursue single embryo transfer. Our problem is, when will the time come? Hopefully soon.
Well spoken. And if I may just also throw in a comment there, and I think another thing is driving our multiple rates in Africa, and that is that so many of the pregnancies are lost to follow-up. So we do not necessarily have the data. We're now beginning to have the data from the registry, but I think there is not enough connection, and I'm speaking generally, between the patient once she's pregnant and the delivery and the AAT centers following up. So we do not always have the outcome in front of us, and particularly also the adverse outcome. So I think with better follow-up and better visibility regarding outcomes of multiples compared outcomes of singletons, maybe that will also add a contribution. I just wanted to add that as well.
Yeah, thank you. Dr. Wada, just to pick up from where you left off concerning funding, we do know that it's a big challenge, isn't it? It's huge. So what are we doing in Nigeria? I know that there are some things being done in Nigeria to include the government in terms of funding and things like that. Do you have any blueprints to share with the rest of Africa to see how effective has that been? And do you have any blueprint to share just to solve that problem of funding?
I'm sorry to disappoint you. There's no blueprint to share. but that's not to say it's not work in progress. The key word for us is the principle of coming together. You see, everyone has their little corners, but that's fine at the beginning of such scientific revolution, if you like. But the science has matured in our hands in a way that not everybody must have their PGT lab or their IVF lab, and these are high intense cost things that must be transferred to the patients. So imagine if there was one lab or two in a big place where little people can come and do the work and contribute to it and share in overheads and so on, the cost burden will come down. And that's a funding principle of its own, if you like, the hub and spoke method of doing IVF. So I believe, at least in Nigeria that I know much of, the time has now come that we must come together to reduce the cost burden on our patients. Is there any other magic way that one can bring a protocol that does that, except in minimizing stimulation and all those efforts that people are trying? If not, there's nothing really I have to share with the world, or with Africa for that matter, in how to, other than this sharing, come together, share.
Yeah, I quite agree with you that it has to be a joint effort. It's something that we have to come together to do. And I think that would go to Dr. Paversan. Is there any role that ANARA is playing in that, in kind of integrating different countries together to not only share data, to see how we can move the practice forward, legislation, things like funding? Is there any role ANARA is playing in that?
Thanks for that. Yeah, I mean, at the moment, our focus is mainly with the data collection between countries, but of course, we do feedback data to individual countries and individual societies and give them the capacity to use their data or their country's data to access their governments and their local funders. So the one example was the South African data going back to South Africa. I know that there's been some data, I think, in Tunisia that's gone back, and particularly as well in Egypt, where we feed back data to the national registry, which they then use in their own efforts with their countries. So as we grow, as we build capacity, we share experiences, we share knowledge with our partners across the continent, and work together and grow together towards achieving all of these goals that we all want to build together.
Thank you very much.
Thank you.
I have one question more again from Dr. Kirandi, and I have the same question to Dr. David Moroll. It's about the training. Do you have any measurement, or how do you measure the effect of just 1 day or 2 days workshops? Is it not enough for the practical work? Yeah,
thank you for that question, and I think it highlights a significant point, really. That the workshops that we can provide over 1 or 2 days are not a substitute for a good formal training program. They will give people an insight into how they do their own on-site training. So, for example, if we take embryo biopsy as a really good example, what we will do is show them the basic techniques, and we stress to them that they would have to go away and develop a training program, or at least record their own on-site logbook of practice. So we're giving them a little bit of a helping start to do their own in-house training. We can't realistically, in a 1 or 2 day workshop, take someone from new to a technique to competent in a technique, and we're always at pains to make that clear. So those are really introductory sessions to give people the basic skills to then develop them themselves. Do we have a way of measuring it? That again is very, very difficult. So we will, as part of our workshops, talk about these logbooks and also developing their own personal KPIs. We always measure the perception of the courses we do. So we have a system whereby we record data that shows whether people value what they've got from the course. What we can't do is actually measure whether they go away and develop competence over time. That's just not within our capability at present.
Thank you.
I would just like to say it's almost time for us to wrap up now, but just asking all of you, what's your experience you've had of cross-border within the African nations treatment, and how does that affect the registry? Because I presume that some countries there'll be a big pull and a big push. So I'd also ask Pav and Silke, and then of course anyone else that has any data on that, just before we leave Silke to wrap up. But that's one a burning question which I'd like to see if you know the answer to.
Yes, thanks for bringing that up. Actually, it is a burning issue in not only Africa but in many world regions. The reproductive tourism and cross-border care. I wouldn't call it tourism in Africa for that matter, but perhaps it's more accessing care from regions where you don't have access to care, driving it. So it is a big issue. Well, not issue from following up, particularly from following up pregnancies and patients being lost once they go back to their home countries. And it's going to take a concerted effort for all of us to come together to find ways of following up these pregnancies and the outcomes that happen thereafter. So yes, it is happening. It's happening quite a lot, and it's quite difficult to follow up these pregnancies and the outcomes, as one would imagine.
Yeah, I mean, just to corroborate that, our registry, our cycle-based registry, captures information on cross-border care and the reasons for cross-border care. And I think many patients are moving across the continent, and also some are moving out of Africa, and then are patients moving back into Africa. Expats who are living elsewhere and who want to come back for care in their own country. And I think it is very important to capture that. You said there's a push and a pull. What ANARA is not trying to do, or has agreed not to do, is compare results of countries within the registry. So we report the procedures by country, and for the rest, like Latin America, we report the results for the regions. And the country data go back to the countries, and what countries do with the data, that of course is their decision. I mean, perhaps Dr. Ibrahim wants to add also, I think Nigeria is also very much in the center of patients moving in and out of the country.
Yes, thank you, Silke. This is true. I mean, our last international conference focused on cross-border fertility care. And like many other things, we've not kept up-to-date data that we can point. But anecdotally, I can almost say that an increasing number of cycles are cross-border cycles. But is it cross-border within Africa as much as across the board, other cross-continent care? So I think that point needs to be made. We have more people from the continent, outside continent, than within the continent. So, and what's the proportion? I mean, within Africa, coming to Abuja under my supervision, 1 to 5 or 1 to 10. 10 will be coming from Europe or America, whereas only 1 will cross from Niger or Chad or Senegal, something like that. Yeah, so I think that's some statistics for you, Giles. Most focus of cross-border fertility care will be from the more advanced societies.
Thank you. Silke, shall we wrap up, do you think?
Yes, I think it is time to wrap up. And it gives me the opportunity to thank everyone who's participated in the webinar. My co-moderator, Adedamilola Atiba, Manar Hozyen, of course, Giles Palmer facilitating it. A very special thank you to our fantastic speakers, Dr. Paversan Archary, Dr. David Moroll, Dr. Ibrahim Wada. And thank you to you all, the audience, for being here with us this evening, for participating, and for the many rich questions you've asked.
And we would like to say thank you to our wonderful I3 team. Thanks to the organizing committee of this initiative, I3, Woha Jacques Cohen, Peter Nagy, Mary Hen Sevates, Thomas Elliott, Fran Fali, and Violeta Sara. Thank you so much.
Thank you again for the talk that was kindly sponsored by Cooper Surgical. If anyone wishes to support I3 or sending any interesting topics for the upcoming webinar, we would be very grateful. Thank you.
Okay, and thanks again from me. It was a fantastic session. I can see opportunities. We can see the amazing work that's going on through collaboration. And I think we're going to have to revisit this again because there's such a rich opportunity here, but a lot of work to be done. In our next session, it's next week, 14th of November. It'll be sponsored by Zymote Fertility, and it's all about conventional insemination. So we'll have sperm preparation, vitrification of sperm, and uncovering the molecular basis of fertilization. So please join us next week as well. Until then, stay safe. Good night.